So what I will be covering will be the ethics principles and issues in genetic testing, and specifically navigating implementation challenges. And then I will look at the framework that is being developed for the return of research results as part of this project. And then I will provide an example of one of the outcomes of the project, which is based on a pilot feasibility study that was performed using bracket 1 and 2 point of care testing combined with genetic counseling. And finally, I will present a case study that reflects the ethics principles of beneficence and a duty to warn and recontact patients. The next talk, as you can see, will be presented on the 3rd of June, where I'll be going into more detail about the implementation phase and also the pilot involving medical schemes. So just to briefly recap on the principles of ethical practice, as all health professionals are familiar with them and should be operating within them. So we've got the principle of autonomy, which is independence and self-determination. And that is basically being free to make one's own decisions. So for patients to make informed consent decisions without being coerced into anything. Then we've got non-maleficence, and that is doing no harm. We've got the principle of beneficence, which is doing good, doing the right thing to promote well-being. And then we have the principle of justice, which basically involves being fair and the equal distribution of benefits and burdens. So the distributive justice, justice has there's three types of distributive justice. It's distributive, so that is the fair distribution of limited healthcare resources. Then we have rights-based justice, which is a respect for people's rights, such as the prohibition of discrimination. And then we have legal justice, which is respect for the law. And then we also have additional derivative principles, which have become very important in medical practice, which is the rule of fidelity. And that is to keep all the contracts and promises to the patient. So not to overpromise and underdeliver. The rule of veracity, to tell the truth and be honest always. And then we have the rule of confidentiality, which is not disclosing information that is shared in an intimate manner, and the rule of privacy. And these two has become an essential, the latter principles have become an essential part of patient autonomy, which includes the right to privacy, hence the doctor's duty to maintain confidentiality. So when we consider genetic or genomic testing as useful tools for improving health and preventing disease, we need to always consider that it deals with sensitive personal information that could significantly impact a patient's life or that of their family. And it's therefore imperative to consider the ethical, legal, and social implications of genetic testing. And here I'm just showing you a 2021 publication in the Journal of Medical Ethics that reviewed a number of documents that were published by international organizations to identify the parameters that define these ethical, legal, and social implications and the recognized criteria for genetic testing and the concerns raised by genomics research. And so in the figure on the right, you can see that there's a list of 29 reference sub-criteria related to genetic testing, which were organized and grouped in the table on the left into 10 minimum criteria, including 2 from the ethics field, 4 from the legal field, and 4 from the social field. So the first 8 sub-criteria that is listed are the most referenced in publications. So there's a paucity of publications on them spanning 2012 to 2019 with informed consent and respect for privacy and confidentiality, both of which fall within the ethical criteria, being the most recurrent theme published on in relation to genetic testing. So the frequency of publications and guidelines around informed consent really reflects its importance in our responsibility as HPs to make sure that this ethical construct is soundly applied in genetic testing and genomics initiatives. And so what I've listed here is just some of the important things to consider that has, of recent years, become really imperative to consider when setting up informed consent. So there's different elements. And one of the things that have more recently come up is the importance in including what happens to the patient's sample so that it is not exploited for commercial purposes, or for use that is not consented by the patient. So we need to also say if it is used for quality control of other tests and whether it will be placed in national data sets or registries. And then we have the aspect of testing children in which informed consent plays a huge role. And the timely medical benefit to the child is seen as a primary justification to perform genetic testing in children. And the ASHG and the ACMG has contended that providers who receive requests for genetic testing in children must weigh the interest of the children and those of their parents and families, and that it needs to reflect a respect for the child's autonomy, which considers the child's intellectual capacity and developmental stage, and also family dynamics. So there are a number of questions that we need to ask, which will inform whether testing in children is justified, such as, are there any effective interventions that will be available with the genetic testing results? What is the age of onset of the condition? Can the testing be accurately interpreted? Amongst others. Another important and highly publicized issue is the issue of incidental and secondary findings. And then there's also an emerging duty to recontact patients. So previously, there was a study in 1995 where almost 300 genetics health professionals were interviewed and asked whether they think we have a duty to recontact participants. And the duty was kind of seen as a one-way street. They highlighted the challenges in recontacting participants and the challenges in the extra time that needs to be spent and resources and things like that, and said that the onus actually falls on the patients to recontact the clinicians or the health professionals. But in follow-up studies, we've seen that duty is more of a two-way street, and that consent should now allow for health professionals and researchers to actually recontact participants should new research have become available or new variants has been classified. And also we need to advise patients that they need to come to us, they need to come to clinicians and researchers should there be changes in their family history or family information that could change the recommendations for management. So the duty to recontact goes both ways. And then there's also a warning of risk to others. So it is believed that we have a duty to inform other relatives, especially when interventions can modify the outcome of the condition, and that we should actually promote sharing of data, of clinical data and family history amongst health professionals and family members if it is relevant to the needs of the family. And this is one that can actually cause a conflict between the duty to warn family members and the autonomy and protecting the confidentiality and the privacy of the patient. So these are all things that needs to be weighed up, these different ethical laws, when looking at them on a case-by-case basis and in consultation with our colleagues. So in 2019, Nimbawari published a framework for tiered consent for health genomics research in Africa. And I'm just briefly going to touch on it. Prof. Potso was also an author on this paper. And they contended that to undertake genomic studies with an ethical mandate, research participants must be properly informed. Their data or sample use preferences must be accurately understood, faithfully recorded, and implemented with integrity. And in order to do this, they proposed a framework for undertaking ethically sound, tiered informed consent in Africa, and provided a comprehensive guide on compiling participant information and they provided an informed consent template for capturing participant consent information and mapping it to a data use ontologies. So we know that there are challenges for conducting research, genomics research, specifically in Africa, and these are logistical challenges related to recruiting patients, and also challenges related to knowledge and poverty-related vulnerabilities. There's challenges in ensuring that patients are properly informed and truly consenting, and ensuring that they retain their autonomy and agency in an era where African genomes are likely to be or amenable to be exploited. And so they've proposed this tiered informed consent framework, which I've just listed here and will briefly go through. So they contend that the consent form must provide information about the genetics, the focus of the study, who's doing the research, what the participant will be asked to provide or do in the study, what the potential risks and benefits of the study will be. It must specify data protection and data and specimen protection protocols. The return of the results is very important, whether they want the results to be returned or not, what kind of results. And so they've set up a bunch of questions that can be asked in this tiered informed consent, such as the agreement for collection of the data or samples for the primary study, an agreement for the secondary data or samples used for other studies, an agreement for general secondary data use in unrelated studies, agreement for inclusion of aggregated data, for example, genome summary data for the study, an agreement for recontacting and follow-on studies, an agreement for the return of defined genetic findings from the current study. So only returning genetic findings that is related to the reason for testing, and also an agreement for the return of unanticipated findings, such as incidental findings or secondary findings, which is not related to the disease in question, but for which guidelines do exist and which is considered actionable. And so this is just a visual of the consent form that is used in our research studies. We have found that it is sometimes very difficult for people to answer lengthy consent forms, and that this one works well as it covers the most important aspects, such as what will happen to the sample, whether it should be destroyed, whether we can store it for a minimum of 5 years, or whether it can be used for follow-on studies but needs to be decodified. It also specifies how long the sample will be stored, and that a material transfer agreement has been drawn up with any collaborator, research collaborator, third party. If the blood sample or specimen provided is stored, is there a chance that it will be used for other research? The participants must consent to this, and how their confidentiality will be protected. So this consent form was approved by the Ethics Committee of Stellenbosch University under the application of personalized medicine using an integrated research service and research approach project, which ensured that the genomic data that comes out of it is appropriately secured, that it's POPI compliant, and that the risk to data security is balanced against the potential benefits to participants, that patients understand all the risks involved in ongoing monitoring of the legal environment of performing research studies, the benefits and acceptability of public-private genomic services, and that all these practices are accepted according to HREC and a data access committee that has been set up to manage these data protection laws and to see that data collection, storage, and use is performed in an ethical manner. So the Open Genome Project. When we think about personalized medicine, currently, we mostly focused on prevention through a genetic diagnosis and prevention through family screening. But more recently, next generation sequencing has enabled us to look at so many different spheres that includes recurrent risk prediction, the metastatic potential and targeted therapies related to a specific diagnosis, and also the area of survivorship. It's made it possible for us to really incorporate different phases of the patient's diagnosis across the continuum of care into a management plan that will span from diagnosis to survivorship. The problem that we face is that it's very challenging to integrate this complex data. And for this data to be assembled, curated, and interpreted with all the other data in order to keep the patient, in order to make sense and actually improve the clinical management of the patient across the span of their diagnosis. We also need to ensure that all of these, when we integrate all these different kinds of information, that it's done in an ethical manner. And a lot of ethical challenges has arisen, and we've encountered them and tried to address them as part of this project. So we've tried to turn the challenges into implementation research, and we learn as we go along. And what we've seen is that the interpretation of data that is generated from complex non-communicable diseases is included the clinical application of genome sequencing in disease management. And because genes alone do not explain a patient's entire phenotype or clinical profile, we know that in monogenic disorders, it is a little bit easier because you find the mutation, you can diagnose the patient. But in more common polygenic multifactorial conditions, such as non-communicable diseases, where there's an interplay between the genetics and the environment, we have to take into account high risk, moderate, and low risk genes with medication, lifestyle, diet, and environment that is reflected in the blood tumor results and the pathology of the patient. And that usually will determine the response to treatment and the health and disease outcomes of the patient. So it is difficult for us to integrate all this information and integrate the pathology and the environmental factors with the genetic information in a way that will benefit the patient. So in order to bridge this gap, we've developed a dynamic genomics database called the Open Genome Registry that has been established between the interface of the laboratory and the clinic. But the Open Genome Project really started due to this case that I'll tell you about. So in 2013, Prof. Kotz's husband was diagnosed with lung cancer. 23 years after his brother sadly died of the same type of cancer at the age of 38. A long-standing friend, Jane, and colleague of ours, had a brother who was also diagnosed with prostate cancer at the age of 49. And her father and most of her 7 brothers had died of cancer. And Prof became aware of the diagnosis then at that stage of a friend who went to school with her called Elna Symington through a post on Facebook. And she was diagnosed with advanced ovarian cancer in the year of 2012. And sadly, she passed away in 2017 after experiencing severe drug side effects from treatment of metastatic ovarian cancer. The side effects that she had was persistent low abdominal pain. And she also had shared with Prof fears of losing her job if she could not return to work soon. And she'd also wished to see her unborn grandchild. So it is Elna's life story that was the inspiration between the Open Genome Project, which was an initiative to optimize the clinical management of patients, of each patient, by using an integrated service and research approach. So Prof actually, in 2016, when she spoke to the patient, she asked her if she could offer her a new tumor test that had become available at the time. And she spoke to the patient's doctor agreed. And then the hope was at that time that gene expression profiling, or finding the specific driver mutation, will be identified. The hope was also that anti-cancer drugs indicated as potentially beneficial will be available in South Africa, and that treatment would work for her. Now, when this tumor test was done, we had found crucial insights into Alma's case. There were a number of things that we learned through her journey. She had had a number of treatments after that. Some had worked, some had not. But this was all part of the journey and the experience, and having had that collaboration with her clinician, and integrating previous information with current sources of information that could help us in giving her the best management at the time. Excuse me. The crucial insights that we had learned was that next generation sequencing excluded BRCA1 and 2 associated ovarian cancer in germline DNA extracted from whole blood. We've excluded PARP inhibitors as a potentially beneficial targeted therapy in both the germline and tumor DNA. And tumor DNA uncovered the causes of past treatment failures, and immunohistochemistry suggested topoisomerase 1 inhibitors as a potential therapy. We could also improve clinical outcomes through expert consultation that led to a carefully monitored treatment plan. Correlating biochemical test results with genetic data supported steps to strengthen the patient's immune system. And significant pain reduction was seen, which highlights the promise of personalized treatment. And this opened new avenues for research by using the beneficence principle in aligning clinical service delivery with patient needs, guided from a unique germline and tumor profile. We also saw that apart from the insights gained by the liquid biopsy, lack of full insurance coverage emphasized the cost of therapy to patients. Serious side effects stress the need for research focusing on better quality of life and follow-up studies, and the patient's willingness to share her DNA data highlighted the need for an interdisciplinary approach in precision oncology, despite ethical and legal challenges. So when Prof asked her if she could post the DNA sequence data with a treatment outcome on this platform without revealing her name, her response was, "I'm no one special. My name can be used anywhere. There are so many women in the same situation. Please do not waste time." So this is a decision-making framework that has come out of that ethics paper that includes the story of Alma. And the decision-making framework is for navigating the ethical challenges anticipated during the implementation of NGS that extends from first-tier point-of-care testing to genome sequencing using a pathology-supported genetic testing strategy to integrate service and research. Genetic counseling support is provided throughout the process, involving the use of research translation tools that requires technical capabilities to increase access to precision oncology with clinical oversight, and also the consideration of different perspectives and accepting shared responsibility for addressing potential ethical issues that may arise during the laboratory implementation phase, as well as decision-making based on patient preferences and reflecting on the outcome of genetic and genomic testing service delivery in parallel to the generation of a research database to support best practice in personalized medicine. So what we want to do is maximize beneficence in cancer patients, but that can be quite challenging because patients respond differently to therapy, and that is because there are diverse signaling pathways that comes into play, and these can range from a deficiency in double-stranded break repair to microsatellite instability and hypermutated tumor status. And so maximizing the beneficence in every patient can be challenging, as we need to be able to accurately test for these things and identify these diverse signaling pathways. And for that, we need the infrastructure and we need support systems so that we can bridge the remaining clinical implementation gaps and address the healthcare disparities and align incidental findings of germline pathogenic variants in the tumor with concurrent familial risk. And this is limited in Africa. There's also a lack of a healthcare model that is designed to characterize and to gain a better understanding of all these requirements. And this is what previously resulted in the development of a pathology-supported genetic testing platform, which enables the application of personalized medicine through integrating research and service. And this approach provides a means for us to balance societal interest in the advancement of generalizable knowledge with individual benefit. Data sharing across diverse healthcare domains is imperative, and it provided the opportunity to bridge the disconnect between inherited disease and associated comorbidities, as demonstrated in a publication by Gknowmix, where we saw that breast cancer patients also are at risk for osteoporosis that is due to vitamin D deficiency or based on aromatase inhibitor treatment. So the ethical requirements from single to multi-panel tests incorporating point of care for quality assurance and the pre-screen report to make sure that the relevant information is captured for accurate interpretation is one of the outcomes of the OGP. And the solutions that is used by the OGP is ensuring proper informed consent, allowing subjects to withdraw from research, addressing secondary and incidental findings, reviewing of cases and publications by HREC, minimizing harm by involving a multidisciplinary team of professionals that includes genetic counselors, and also robust educational efforts on the patient and provider level, such as this Gknowmix meeting platform, and also institutional governance on privacy protection, on safeguarding informational self-determination, and data harmonization for maximum protection of individuals and their data, while ensuring lawful exploitations of the benefits for future generations. So if we look at the current state of testing in breast cancer patients in the context of justice and equity, distributive justice, we look at the private sector compared to the public sector. There is there is a stark contrast in what is accessible to patients. So in the private sector, previously, the analysis of BRCA1 and 2 was focused on surgical decision-making and to inform family screening. Currently, what we can do with that information is use it to justify for the treatment with PARP inhibitors. So we can use it as therapeutic targets. In the public sector, however, the analysis of BRCA1 and 2 is focused on surgical decision-making and only sometimes to inform family screening. Due to a lack of infrastructure and resources in the public sector, family screening is rarely done as it should be. There is a need to contact family members, inform them of the risk. But the problem is, where will they get screened? They will then, in individuals who we identify pathogenic BRCA mutations, they need to undergo surveillance. And that is quite a costly exercise, and they are not currently accommodated in the public sector. And currently, we do not have the availability of PARP inhibitors for BRCA-positive patients. So the finding that both germline and somatic BRCA variants respond similarly to PARP inhibitors ushered in a new era of personalized medicine where the boundaries between germline and tumor genetics have become a bit blurred. So there's new ethical challenges, such as the detection of variants of uncertain clinical significance and complexities in communicating meaningful laboratory results. So the beneficence in biomedical ethics relates to the obligation of healthcare professionals to ensure that actions collectively translate to patient benefits. So I guess the question of justice and distributive justice and equity amongst these two sectors, we are definitely not there yet. However, the NHI bill, as I'm sure you are aware, have been signed during last week. And that bill aims to improve access of patients in the public sector to private healthcare. Whether it will work, we are not sure. I'm not going to comment on that. But we are in a resource-stricken setting. And so there are a lot of concerns as to how that bill will be translated in real-life settings, given the situation that we are already in with the lack of infrastructure or the lack of effort in updating infrastructure and quality services. But I think what is for sure is that we need to get we need to have proper ethical oversight over that process to ensure that it is implemented in the proper manner. So the emerging duty to return genetic information is based on the principles of autonomy, beneficence, and the acknowledgement that translational genomic research cannot progress without the engagement of research participants. And the return of research results to participants is, however, challenged by many factors. That includes the lack of resources, as we know, and skilled personnel for variant confirmation and patient follow-up, as well as the complex nature of integrating genetic findings into personal health care. Generally, a broad range of clinical information, including pathology, needs to be collected for genetic information to be meaningfully interpreted and returned after provision of proper informed consent. And to satisfy these requirements, a pathology-supported genetic testing platform was developed at the interface between the laboratory and the clinic. And it was developed in South Africa and pioneered in Kenya through the development of a process for the return of actionable research results. The elements that were essential to this process included the establishment of collaboration channels for lab testing and patient referral so as to promote multidisciplinary case management, as well as overcome the infrastructure and resource barriers related to variant confirmation and feedback. The Open Genome Registry was pivotal in capturing data sets that were routinely evaluated for accuracy and completeness by providing ethics-approved access to clinicians and pathologists to ensure data integrity for the feedback in the form of scientific publications and for use in cost-effectiveness studies and health technology assessments. In this Kenyan study that was process that was piloted in Kenya, 97 patients with histologically confirmed breast cancer who attended the Moi Teaching and Referral Hospital for treatment between 2013 and 2016 were enrolled, and the informed consent used was adopted with permission from a South African study that makes provision for the feedback of research results to participants. It was explained to participants that genetic results interpreted in a clinical context may be made known in cases with a definite risk for developing a second breast cancer with a predisposition to other risk factors, a predisposition or risk factors that is treatable or avoidable, example by lifestyle or dietary modification, and or who may need genetic counseling. And then a material transfer agreement was signed between the Moi University in Kenya and Stellenbosch University in South Africa, and an export-import permit obtained for sample transport to Kenya, from Kenya to South Africa. But this consent was piloted in 16 females who presented with breast lumps to gauge the ability, to clearly and sufficiently relay information regarding the design and goals of the study conducted at Moi University, and when necessary, an interpreter who could speak the patient's native language was engaged to help translate information in the consent form. In order to determine whether the patients understood what was discussed during the informed consent process, they were asked to repeat in their own words what had been explained to them. And a questionnaire was administered to obtain various clinical and personal information. An effort was made to ensure that participants understood how the study related to their breast cancer diagnosis, recurrence risk, and family members. Most of the patients needed further clarification of the medical terms, as was found in the study. Terms such as DNA and hormone replacement therapy, as these terms have no equivalent translation in native African languages, and therefore it required extra time for an explanation in an attempt to improve patient comprehension. A young patient also hesitated to provide informed consent, as she said that she cannot read or write, and she was ashamed of people to know about it. And we know, and it has been reported, that a major barrier to effective consenting is the level of literacy. And so it becomes even more imperative for us to think about ways to overcome or to improve genetic literacy, such as community engagement, and also with the use of visual tools and language tools to facilitate the informed consent process. So the challenges encountered during the informed consent process were contextualized into a framework for the return of research results to patients with familial breast cancer. And the pre-test process pioneered during this investigation identified problem areas that was addressed by the development of an adaptable WES report that enables disclosure in 5 steps, as can be seen. So step 1 was reviewing the informed consent form. Did the patient select sample storage with the option for return of results? And then confirmation of WES results. So one patient was found to possess a pathogenic BRCA2 mutation, which was then confirmed with Tango sequencing as the gold standard by a diagnostic laboratory, and then interpretation of genetic results in the context of the clinical information available in a research database. Step 4 was follow-up studies and clinical management of familial risk. So it was important that we would find out whether the patient would share this information with the family so that the benefit could go beyond the patient, but also to a larger family. So she was encouraged to recontact the institution every few years to review, update the family history, and address new concerns that may be relevant to the family. And genetic counseling, she has agreed, and genetic counseling was performed online with her children. And then step 5 was document feedback from the treating clinician on the clinical utility of WES. So we inquired from the treating clinician how they experience the process and how they will actually use this result. And they recommended that a copy of the report be kept in a file with the patient for future reference. And the clinician was also interested in pharmacogenetics related to tamoxifen resistance and made a note in the patient file regarding that. So the insights gained during the informed consent process was incorporated into the patient report used for feedback as reflected in this table. And what we've highlighted here was pertaining to the review of the consent form was the clinical relevance and the importance of the clinical actionability of the genetic finding, and also the option of genetic counseling as a prerequisite for the return of research results. Some of the considerations are listed there, and one we've highlighted was the importance of long-term participant engagement that allows for open communication with researchers that are aiming to close the gap between expectations and reality, so that two-way street of, or the two-way duty to warn, or the duty to recontact. And also the challenges that was addressed in the report are listed there. And what is important is that the report that we have provided to the patient facilitated the evaluation of clinical characteristics in relation to inherited and lifestyle and therapy-induced risk implications. So as part of the Open Genome Project, we performed a pilot feasibility study, and this was presented at the Academic Year Day in 2022. And it looked at point-of-care bracket testing incorporated into a dynamic genetic counseling process. And the aim was to determine the clinical utility of combining genetic counseling with point-of-care genotyping as a first-year test towards differential diagnosis of breast cancer. And what we did was, in 7 breast cancer patients seen in private practice, we took buccal swabs. We took dual samples, buccal swabs, and also saliva samples for comparison. And we extracted the DNA from patients' blood as well for comparative analysis at the NHLS and other accredited diagnostic laboratories. And the test kit that was developed for breast cancer genomics on the para-DNA point-of-care device comprised all of the reagents that were required to amplify targeted DNA sequences and detect 8 founder pathogenic variants, which has now been extended to include 9 variants. The para-DNA software was then used for analysis and interpretation of genotype calls. So the patient were referred in private practice, samples were taken, including buccal swab, saliva, and then also a comparative blood sample for diagnostic confirmation. The test was then ran immediately after counseling in the clinic, and that from sample input to completion, it takes about an hour and a half, actually less. After which the para-DNA generates an automated report with the genotypes as listed there. And that is then incorporated into a pre-screen algorithm where the BRCA genotypes are automatically combined with patient data, such as histopathology and patient lifestyle questionnaire on the Gknowmix platform. And then semi-automated report is provided to the patient, and it suggests the most effective management or additional testing that may be required according to the patient's specific genotype data and medical history. So we found that of these 7 patients, 2 tested positive for the BRCA 8162-Del-G variant using the point of care, and diagnostic confirmation was performed by sending the samples away, as this was still done in research. So it was confirmed in a diagnostic lab, and once the results were available, the patient had opted for bilateral mastectomies with reconstruction, and one of the patients was actually scheduled for surgery during the same week. This patient contacted Prof. Kotze after a RSG radio interview with Marie Hudson, who's also a staff member, and she was at that stage interested in the mama print, but she did not qualify due to her T-positive status. And during that conversation, Prof then asked her about the possibility of germline testing, and she agreed. And following confirmation of her results, I then saw the rest of her family as well. So in the 2 patients who tested positive for BRCA mutations using the point of care, their results had immediate clinical action. And then in the 5 patients who tested negative, we then recommended extended testing using NGS or WES. And one of those patients were found to carry a non-founder BRCA mutation using an NGS panel with a turnaround time of 3 to 6 weeks. So whilst NGS technologies are effective in informing patient management, and it is becoming more widely used, even in the private sector, the turnaround time is still lengthy, and it can sometimes limit timely application of the results in clinical practice. And with the BRCA founder point of care genotyping during or immediately after genetic counseling minimizes the risk of sample mix-up, as we've seen in an example where that has unfortunately happened in the laboratory, but we were able to pick it up due to the point of care that was also performed alongside other methods. And it also minimizes the need for separate appointments for sample collection and transport. And first-year test results, which otherwise may have been delayed, enable timely intervention in 2 out of the 7, or 30% of the patients, without incurring further costs and inconvenience to patients. So this is a case study that was also a sort of a large endeavor as part of the Open Genome project. I think I'm just going to give you a quick review of the case study, but I will definitely expand on it during the next talk. So I invite you to please attend the next talk, where we will hopefully have the outcome of this case report, as well as the outcome of the medical scheme pilots. So this was a case that was referred to us in 2017. This patient had 3 primary breast cancers, and at that stage, BRCA1 and 2 has been excluded, and we had offered whole exome sequencing. Whole exome sequencing results showed a positive, the whole exome sequencing picked up a mutation in TP53, and we initially said that it was a positive result in the report, but we had sent the report out to the clinician to make them aware that we need to do further investigation, we need to do follow-up studies, we need to do family screening. At that stage, there was a clinical assessment done by a medical geneticist, but they had not considered a diagnosis of Li-Fraumeni syndrome, which was only kind of elucidated after follow-up counseling performed by myself when I did some more digging into the family history and found that there was another case of brain cancer in addition to the lung cancer, 2 times melanoma, and various other breast cancers that were diagnosed in the family. At that point, our attention shifted to a possible clinical diagnosis of Li-Fraumeni syndrome, but we couldn't. We recontacted the patient's clinician, and that was the start of a long journey that included a lot of different genetic tests, genomic tests, functional studies, in order to try to classify this variant. We have not made a classification yet, as we are still waiting for protein studies, immunohistochemistry to be done. At the moment, we have collaborated with various members of the strategic and technical advisory panel. These are all scientists, technical scientists, experienced in variant classification. And we have gotten the input with everybody. And over time, the classification of the variant, or the proposed classification of the variant, has changed with new information coming to light. But this case really just demonstrates our efforts into trying to help the patient and trying to get an answer for them, so that we could, so that this whole process might benefit the patient, improve their management, and also benefit the rest of the family. As you can see, here's the family pedigree. Our patient is over here. She developed 3 primary breast cancers. She also received radiation therapy, but that was based on the tumor pathology. So that was based on a clinical profile. So it becomes very important for us to be able to classify this variant to inform future management of the patient and reduce the risk, treatment-related or other risk, in herself as well as her family members. She had 2 sisters also with breast cancer, one diagnosed at the age of 34. Her mother had 2 melanomas and a lung cancer. And then there are various other cancers. There's a brain cancer that was diagnosed at the age of 51, which shifted our attention to Li-Fraumeni, which also fits the criteria for this variant. And then there's also there's 2 lung cancers, and there is cancers on the paternal side, which we've also actually used to do segregation analysis of the variant. Now, the reason why we did so many analyses with this variant is because the variant was not found in a canonical transcript. TP53 has many isoforms with different functions. And so when we found out that this is actually the beta isoform of the TP53 gene that was so rarely published on, it was only found twice in a tumor database. We had to do further analysis to make sure that this is actually the cause, or the potential cause, of what we see in the family. Here we also did, we also performed protein modeling studies using MD-TAS software that was applied to construct dynamic residue networks for the beta isoform variant and the wild type proteins. And these results showed that that particular variant might affect the behavior, that might actually steer conformational changes in the protein, and it actually pointed towards altered protein structure, which could potentially affect protein function. We've so far done functional studies as a new addition to the pathology-supported genetic testing platform, and that was just recently published. And these studies pointed also to a deleterious effect of the TP53 beta variant, which, if concluded by further protein interaction studies, which are pending, will help us to actually classify the variant. So we are not classifying it just yet. We are waiting for the tumor staining results, and then we will hopefully get to a classification so that we can finally provide the family with the reports and recommendations for future management. And this would not have been possible. These are all the tests that we've done, and this would not have been possible with all our collaborators. I'm sure are all attending this meeting this evening. So we thank you greatly for your involvement in the study. As you can see, BRCA full gene screening was done. Whole exome sequencing was then done. We did bioinformatics, in silico bioinformatics, co-segregation studies were then performed. We then did whole exome sequencing to exclude mutations in the promoter regions of BRCA1 and TP53. We also did splice variant prediction. We did the point of care as an internal control. We did MLPA of TP53 and CHEK2 and the entire BRCA1 and 2 genes. As we saw that CHEK2 mutations can also account for the Li-Mini-like phenotype. We've done functional studies which show supportive evidence for the functional impact. And then now we're just waiting for the immunohistochemistry staining, which will hopefully be done soon. We've heard that the antibodies will be received this week. So hopefully during the next meeting, we'll be able to feedback on the outcomes of that test. So this whole process was followed due to our duty to warn and to recontact patients. We felt that this family have had so many cancer diagnoses, and there could have been a missed opportunity to prevent cancers in the family, and still, if we do not classify this variant. And so as part of the OGP, we needed to follow this process of variant reinterpretation so that we can hopefully figure out what to do with this family to prevent them from developing cancer in the future. And genetic counseling is also crucial for this process, from getting informed consent to keeping the patients up to date regarding the study. I've been in contact with them since the beginning of the study, keeping them updated so that they also know where we stand and when they can expect to receive an answer. As a result, will definitely have a huge bearing on their management moving forward, such as the risk to their offspring or their children, and also the recommendation to avoid carcinogens such as sun exposure, tobacco use, occupational exposures, and also the minimization of diagnostic and therapeutic radiation. So we've seen through this study that ethical issues definitely will arise regarding the disclosure of results to participants. We have many examples, which I did not share in this presentation, but during the next one I will. And the failure to consider patient preferences or disclose pertinent information may lead to ethical injustice. And the ethical requirements that have been addressed by the OGP include the right of subjects to withdraw, very important, as we set up our consent forms, and also taking into account the responsibility that we have to return actionable results, and also managing data sharing risks, and also the importance to perform research using adequate consent with ethical review of case studies, such as the one I've just mentioned, by the ethics committee to protect and benefit research participants. Thank you very much.